Hello, my name is Dr. Dewan as Raja. Today I will discuss about oral herpes stomatitis, also called primary herpetic gingivostomatitis. Definition: oral herpes stomatitis is a viral infection of the mouth and gums caused by predominantly by herpes simplex virus type 1. Rarely herpes simplex virus type 2. It usually presents as painful oral and perioral lesions, particularly in children, but it also happens among the adults. Etiology: primary infection with herpes simplex virus 1, rarely herpes simplex virus 2, commonly acquired in childhood, often between 6 months and 5 years of age, transmitted via saliva, close contact, or fomites. What is the pathophysiology of oral herpes stomatitis, also called primary herpetic gingivostomatitis? Pathophysiology: initial infection involves viral replication in epithelial cells, leading to cell lysis, vesicle formation, and ulceration. Herpes simplex virus then travel to the trigeminal ganglion. There is the trigeminal nerve, that is a cranial nerve, trigeminal or fifth cranial nerve ganglion, and establishes latency there. It may stay in the trigeminal ganglion for many years. Reactivation may occur later in life. Herpes labialis, cold sores. Clinical feature: primary herpetic gingivostomatitis. This is more severe, sudden onset of fever, irritability, malaise, painful vesicle on lip, buccal mucosa, tongue, palate, gingiva. Gingivitis with swollen bleeding gums, vesicles rupture to form shallow ulcers with erythematous halos. Lymphadenopathy, submandibular cervical lymph node may be enlarged, and that is an usual finding. Drooling and refusal to eat in infants and children. So, lymphadenopathy is a finding in primary herpetic gingivostomatitis. Recurrent herpes labialis, cold sores, reactivation of latent herpes simplex virus, cluster vesicles on vermilion border or perioral skin, triggered by fever, sun exposure, stress, and trauma. Okay, stressful situation like a medical student facing a board exam. In that condition, in that situation, you have a lot of stress, or someone lost money in stock, so they are tense. So in that situation, there is recurrent herpes labialis is possible reactivation, and that come from the trigeminal ganglion. Okay, these are the herpes simplex virus gingivostomatitis on the tongue, on the palate, okay, and maybe the lip here, on the skin, close to the mouth. Okay, so how to diagnose? Usually clinical diagnosis, confirmatory test if needed, Jank smear multinucleated giant cell, PCR or viral culture, direct immunofluorescence of or ELISA, enzyme-linked immunosorbent assay, differential diagnosis, aphthous ulcer, Coxsackie virus, hand, foot and mouth disease that is also common in the children, Steven-Johnson syndrome due to some drug like sulfur drug, Herpes, Beecher's disease, there may be genital ulcer plus the aphthous ulcer. In addition to that, there is uveitis. So these are the differential diagnosis. So complication, if you go to the complication, there are many complications like dehydration due to pain, fever, drooling. Infants and young children are the risk group. Secondary bacterial infection, impetigo, cellulitis, or oral ulcer. All age group are at risk. Herpetic whitlow finger infection from auto-infection. Children, HCWs, healthcare workers, okay, particularly the dentist, they examine the teeth, tongue, so they are in contact with this and they may develop herpetic whitlow finger infection from auto-infection or the infection from the patient. Herpes simplex keratitis, eye involvement, dendritic ulcer, there may be pterygium, and this group is children auto-inoculation. Eczema herpeticum, disseminated herpes simplex virus in atopic dermatitis. Okay, risk group patient with atopic dermatitis. Encephalitis, there is inflammation of the brain. This is a very severe condition. Temporal lobe involvement, although this is rare, it is more common in adults than children. Encephalitis or pneumonitis, inflammation of the esophagus, inflammation of the lung. Herpes simplex virus extension of deeper organ, and risk factor, immunocompromised patients. So herpes simplex virus extension to deeper organ. Okay. Treatment, supportive care, hydration, analgesic, antipyretic like acetaminophen, ibuprofen. This is an NSAID. Topical anesthetic, lidocaine, but with extreme care. Okay, because it may absorb to the blood, that may create a lot of adverse effects. Antiviral therapy, acyclovir, oral or intravenous. Most effective is started within 72 hours. Indicated for moderate to severe cases. So acyclovir. We have also other drug like famciclovir, vinylaclovir. Okay, this is commonly used. Indicated for moderate to severe cases. Doses, children 15 milligram per kg 5 times per day. Prognosis, self-limited in most cases. Symptoms resolve in 10 to 14 days. Virus remains latent, recurrence possible. Latent in the trigeminal ganglion or the fifth cranial ganglion, same thing. Prevention, avoid contact with active lesions, hand hygiene, educating caregivers and patients about transmission. And that's all about today's topic on herpes simplex virus stomatitis. If you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe me. Have a nice, wonderful, and blessed day. Bye now.